This is the continuation of our discussion regarding your microbial toxins. So last time, we are done discussing your botulinum toxin and your tetanus plasmine, and we also discussed the difference of your exotoxins from your endotoxins. So let us now move to your diphtheria toxin. So it is produced by your Corynebacterium diphtheriae, and its mechanism of action is that it inhibits protein synthesis via EF2 inactivation. So when you say EF, that refers to your elongation factor 2. So our diphtheria toxin, so inhibit niya po yung protein synthesis by inhibiting or by inactivating this EF2. So major clinical effects, so we have pseudomembrane, we have your myocarditis, and we have your neuropathy. For the management, so we can use your diphtheria antitoxin, which serves as the antidote for diphtheria toxin toxicity. So we can also provide intubation or tracheostomy in case that our patient, of course, is experiencing difficulty in breathing. So this is primarily because of your pseudomembrane that can attach to your nostrils or even dun sa sides ng ating tonsils. And then we can also use, of course, antibiotic therapy wherein our drug of choice is your erythromycin. Another one, we can provide cardiac monitoring, especially if merong myocarditis yung pasyente natin. So, may inflammation of your myocardium. And then we have also your diphtheria toxoid vaccine. Next one is we have your cholera toxin. Of course, it is derived from your Vibrio cholerae. And its mechanism of action is that it activates your adenylate cyclase. So if you can still remember, I hope you can still remember the different receptor families. So, di ba, we have your G-protein coupled receptors, we have your ligand-gated receptors, so on and so forth. So, pagdating sa ating GPCR, so dun po pumapasok yung importance ng activity ng ating adenylate cyclase. So, remember, ang ating adenylate cyclase class, it is the enzyme that converts your ATP to your cyclic AMP. So since your Vibrio cholerae or its toxic substance, which is cholera toxin, activates your adenylate cyclase, it increases therefore your CAMP or your CAMP, and thereby it also increases the activity of your pKa or your protein kinase A. So for its major clinical effects, so there is a profuse watery diarrhea. So ito po yung parang kumbaga hallmark symptom ng toxicity ng ating cholera toxin. So for the management, of course, since we have diarrhea, we should provide rapid fluid and electrolyte. And then we can also provide antibiotic therapy. To be specific, we have your doxycycline, we have zinc supplementation, and of course, monitoring and supportive care. So we need to monitor, of course, yung electrolyte ng ating pasyente. Kung depleted pa rin ba yung major electrolyte sa katawan or hindi na. Okay, the next one is we have your Shiga toxin. So from your Shigella dysentery. Okay, so its mechanism of action is that it inhibits your protein synthesis. To be specific, it targets your 60 ribosomal subunit. And then for major clinical effects, so it causes your bloody diarrhea, and we have your HUS, or it stands for your hemolytic uremic syndrome. For the management, we can provide oral or IV rehydration, and we can provide as well Shiga toxin as parang kumbaga antidote. The next one, we have heat labile toxin. So it is produced by your Escherichia coli. So just like your cholera toxin, ang mechanism of action ng ating heat labile toxin is that it increases the concentration of your cyclic AMP by activating your adenylate cyclase enzyme. Therefore, it also increases the activity of your protein kinase A. So this will result to your watery diarrhea. For management, we can provide oral rehydration therapy, antibiotic therapy. So we can use your azithromycin, ciprofloxacin, and we have your rifaximin. We can also provide zinc supplementation, and of course, we need to practice, or we need to suggest or recommend practicing proper hand hygiene. The next one, we have exotoxin A. So it is produced by your Pseudomonas aeruginosa. So it inhibits your elongation factor 2, causing tissue necrosis and sepsis. So for antibiotic therapy, we can use the following. We have your piperacillin tazobactam, we have your ceftazidime, cefepime, meropenem, and we have your amikacin. And of course, since we have tissue necrosis, we can drain the abscesses present in the skin, and then we can also provide fluid and electrolyte management. Next one, we have your alpha toxin. So from your Clostridium perfringens. So it acts as a phospholipase C that hydrolyzes phospholipids in host cell membrane. So it causes your gas gangrene. So if you can still remember your microbiology, diba, your gas gangrene, it is characterized by a foul odor wherein parang dun sa skin ng pasyente natin is may nag-violet na parang kumbaga bubble dun sa skin natin, and then kapag ka nag-pop yun, yung parang bubble-like structure na yun sa skin natin, it produces or it emits a very foul odor. Okay, so for the management, we can provide immediate surgical debridement. So tatanggalin po yung affected part ng ating skin, and we can also provide antibiotic therapy using your penicillin G, and we have your clindamycin. And aside from that, we can provide hyperbaric oxygen therapy. So when we say hyperbaric oxygen therapy, we provide 100% concentration of oxygen. And lastly, we have your aggressive IV fluids. Okay, next one, we have your TSST1. So I hope some of the or most of this bacterial exotoxins and endotoxins are familiar na sa inyo since we are already done discussing them in your microbiology. So just i-review, diba, we have your TSST1, so that is your toxic shock syndrome toxin 1. So it is produced by your Staphylococcus aureus. So mechanism of action, remember that your TSST1, it is a super antigen causing a massive T cell activation. So for its major clinical effects, we have your toxic shock syndrome. So actually class, yung ating TSS, sa number of cases ng ating TSS class, commonly associated yan sa paggamit ng tampons ng mga babae. Wherein, of course, naiipon po yung blood dun sa loob, causing or parang kumbaga nagpro-provide siya ng environment wherein kaya pong mag-thrive ng ating Staphylococcus aureus, causing now your toxic shock syndrome. So for the management, we can provide aggressive IV fluid resuscitation, remove the source of toxin, antibiotic therapy to be specific, clindamycin, and adjunct therapy by providing your intravenous immunoglobulin. Okay, so we are done with the different exotoxins. Let us now move to your endotoxin. So I think we only have one, which is your LPS, your lipopolysaccharide. Again, diba, based on our previous discussion, remember that your endotoxin, it is a lipopolysaccharide that is present in the cell wall of our gram-negative bacteria. At saka lang po yan marirelease upon cell lysis or cell death. Okay, so for its mechanism of action, it activates your macrophages. So for its major clinical effects, we have fever, we have septic shock, and we have your DIC or your disseminated intravascular coagulation. So for the management, we have aggressive fluid resuscitation. We can provide vasopressor support, especially if our patient is hypotensive. So we can use your norepinephrine. And then we have your broad-spectrum antibiotics, just like your piperacillin tazobactam, cefepime, and we have your meropenem. And aside from that, we can provide oxygen or mechanical ventilation if needed, and adjunctive therapy, just like your corticosteroids. So we are done with the counterpart of your bacteria. Let us now move to your fungal toxins. So we have your aflatoxin, which is produced by your Aspergillus flavus. So its mechanism of action is that it is hepatotoxic, meaning it is toxic to our liver, and it causes DNA adduct formation, or there is a change in the genetic structure. Okay, for its clinical effects, of course, it can cause liver failure and hepatocellular carcinoma. So it can cause cancer. For the management, of course, we need to monitor liver function. So by monitoring the levels of your ALT and your AST, and then we have maintain hydration and electrolyte balance, activated charcoal if there is a recent ingestion of your aflatoxin, and we can use as well your N-acetylcysteine since it is, or parang kumbaga, it reduces oxidative stress, especially if there is hepatic damage in our patient. The next one, we have your ergot alkaloid. So its fungal source, we have your Claviceps purpurea. For its mechanism of action, it causes vasoconstriction and CNS effects. Clinical effects, we have gangrene and we have your hallucination. So what we need to do is that we need to immediately discontinue the exposure, medication therapy like the use of your nitroprusside, nifedipine, and we have your nitroglycerin. And then we can use your phentolamine as an antidote. Okay. Then next, we have your ochratoxin A. So from your Aspergillus genus, and we have your Penicillium. So they are both nephrotoxic, meaning they can cause renal impairment. So for the management, we can provide immediate supportive care, like for example, hydration, medications to replenish our electrolytes, and of course, we need to monitor renal function. Like for example, we measure your serum creatinine and to see if creatinine is eliminated ba ng mabuti via our urine. And then avoid, of course, nephrotoxic drugs like for example, your aminoglycosides. Aminoglycosides are nephrotoxic drugs. And then dialysis if severe, detoxification by using your activated charcoal, or we can provide your N-acetylcysteine as an antioxidant support. And then lastly, we have your viral toxins. So for example, we have your NS1 protein. So main source natin dito class is we have your dengue virus. So NS1 stands for your non-structural protein 1. So for its mechanism of action, it can cause endothelial damage and immune activation. So clinical effects, so it may cause plasma leakage or hemorrhage. So that is why 'di ba meron tayong cases ng mga dengue na nagno-nosebleed yung mga pasyente natin because our NS1 protein, it may cause endothelial damage that will lead to leakage of plasma contents. Okay, so for the management, we can provide fluids like oral rehydration and IV fluids. We need to avoid as well NSAIDs because it can affect the formation of your what I mean is that your NSAIDs can affect the formation of your blood clots because, diba, if you can still remember the breakdown of your arachidonic acid by your COX-1, that will result to the formation of your prostaglandin as well as your thromboxanes, which are important for the formation of your blood clots. And then we can provide as well symptomatic treatment. Like for example, paracetamol if there is fever, and hydration if there is dehydration. Then we can also monitor the platelet and signs of bleeding or shock. And of course, there should be mosquito control. And then lastly, we have your HBX protein or your hepatitis B protein X. So its source, of course, is we have your hepatitis B virus. So its mechanism of action is that it alters gene expression, causing hepatocellular injury. So for the management, we can use antiviral therapy. Like for example, we have your tenofovir and we have your entecavir. And then lastly, we need to monitor liver function, and of course, we need to administer hepatitis B vaccine. So that will be the end of our discussion regarding your microbial toxins.